Muchas gracias. Ahora es 7:30, so please have tiempo de Guatemala. So please have breakfast. We can do that and talk. I don't mind, but I can see everybody. So if you're eating breakfast, not like this, and quietly, but I think that would be good. So thank you very much. We can pull up the slides. I'm going to talk about things that we believed in, myths, but turn out not to be true. And I remember that when I started medical school, one of the old professors came before us and said, I have bad news for you, and I have worse news for you. And we said, oh my gosh, we're just starting medical school and we're getting bad news. He said, the bad news is that half of what you learn in medical school is going to be wrong. The worst news is we have no idea which half that is going to be. So I'm going to go through some of the things that we know are no longer correct. So I have no conflicts of interest related to these things, but I am somewhat biased. So by definition, a myth is a concept or a belief that has no basis in fact. A misunderstanding is like the scientific method. We don't have full knowledge, but once we get more evidence, more knowledge, we're able to move forward. And dogma is the most difficult thing. It's a point of view that you hold on to because you are the boss, because you are smart, and it comes out as being authoritative, but it has no grounds. So we have dogma because this is the way we've always done things, and the patients do just fine. But we don't always know that. So what happens when you have dogma? So I have a story to tell you that has nothing to do with medicine. It has to do with the railroad and spaceships. So when the railroad trains were built in the United States, way back at the beginning, they were built by the British. And they had the trains brought over from England, and so they made the gauge, the spacing between the rails, the same as in England. And that was 4 feet, 8.5 inches apart. They thought it was easier than changing it and building different cars. So these were the ones that did it based on the rail system. But how did they build that gauge? How did they determine it was 4 feet, 8 inches? Well, it was based on the existence of the previous tram lines. They laid the trains on top of those. And where did those tram lines came from? They were based on earlier horse roads that were there in England. And where did those horse roads come from? Well, that axle width, that 4 feet, 8.5 inches, was because the wheels had to make the previous ruts. And they were well-used ruts throughout England that existed before the horse trails. And so, of course, where did those ruts come from? They were made by the Imperial Roman war chariots when the Romans were there, because when they chose this width, it was based on the distance that they thought between the backside of two horses. So let's move forward now, thousands of years, to the space shuttle. This is the US space shuttle, and what you have is the shuttle here, but it goes into space because of these booster rockets. These boosters help it to attain orbit. These were designed and made in Utah, but the space shuttle is on the other side of the mountains. And they had to make the boosters here much longer and narrower than the most efficient design. The most efficient design was by the Russians. This is the Buran, or the Russian, where it's attached and it's thicker and it has a better profile, so it doesn't stick out. That can actually launch 6 times the payload. It has a better lift to drag, and because it's attached, has better thermal protection. So why in the world, in the US, do they use a shuttle like this? And the answer is they had to make the booster rockets thinner so they could be transported after being made in Utah to the space shuttle in Houston or in Miami. And to do that, they had to go through tunnels in the Rocky Mountains. And those tunnels were the same size as the railroad tracks, 4 feet, 8.5 inches. And so the story, the answer to all of this is the most technologically advanced booster rocket design wasn't guided by efficiency, but by a horse's ass. So, why is there dogma? Common sense. Clinical wisdom is the right thing, and if it's not broken, we're not going to fix it. The British Medical Journal every Christmas publishes a very funny series of articles. And if you haven't seen the Christmas issue of the BMJ, you will enjoy it. And in 1999, Dominique Fitzgerald, who's a pediatric pulmonary doctor out of Australia, published a short piece called 7 Alternatives to Evidence-Based Medicine. I would recommend this to you highly. It'll give you a big smile. My favorite of these was something he called eminence-based medicine. And that is, the more senior the physician colleague, the less importance they place on anything as mundane as evidence. They have a faith in clinical experience defined as making the same mistakes with increasing confidence over an impressive number of years. So let's talk about these mistakes, these dogmas. Let's start about cystic fibrosis. Patients with cystic fibrosis, as you know, have pancreatic malabsorption. And when they eat fats, these are excreted. They give very foul-smelling stools. And it was noted that fat in the diet made them uncomfortable. And so for many, many years, fat was restricted from the diet of patients with CF until Kevin Gaskin and others in Toronto decided, what if we helped the fat absorption? What if we gave pancreatic enzymes? And in fact, taking away the fat decreased their bloating, but it led to malnutrition. When they added the enzymes, it magnificently improved their longevity and their health. Dogma. But then they said, well, you know, if we're giving enzymes, these are benign, people eat them. What if we give even more? If a little bit is good, maybe we can give even more. And what they found is giving more produces something called fibrosing colonopathy. And in fact, if you increase the dose from 24 to 50, it increases by tenfold. And if they increase it even more to over 50,000 units, you get a 200 times increase in fibrosing colonopathy, which is extremely bad and difficult to treat. And so only through a period of time were we able to determine what's appropriate. How many of you have recognized the mist tent? I see, yes. Yes, of course. Somewhere in there, right there, is a child. And they used to believe that when you had croup or cystic fibrosis or asthma, give them high humidity. It will thin the secretions. It will make them easier to breathe. It was used universally until the 1980s. But in fact, patients got lost. Some of them even died from not monitoring. They didn't get better faster, and surprise, the inside of the mist tent became colonized with Pseudomonas. And so the mist tent disappeared. Yet, if you didn't start one back in those days, oh my God. I'd like studying mucus. And so I'm going to talk to you about some myths related to mucus. So the first one is that CF mucus, cystic fibrosis mucus, is thick. In fact, in some countries, they call it mucoviscidosis. And in fact, it's not thick. This was a study done by Lynn Reed, who you remember from medical school, the Reed Index, many years ago. And it's the first of perhaps a dozen studies. There are now 11 of them that show that as mucus goes from being grayish and clear to being purulent, it becomes more viscous. And that's true for bronchitis, bronchiectasis, CF, and asthma. But if you compare them across the board, CF mucus is not more viscous. It's actually less. And that's because there's some breakdown from the proteolytic enzymes. And in fact, thin mucus is more difficult to clear by cough. If you can think about a pea shooter where you have a straw and you're pushing out a pea, it's easier to push out that pea than pea soup. And the other thing is that maybe the problem is bad mucociliary clearance. And in fact, that also isn't true. Mucus clearance is unlikely to be the main cause in CF. We know that in primary ciliary dyskinesia, where the cilia don't work, there's no mucociliary clearance starting at birth. And in fact, one of the hallmarks of PCD is neonatal lung disease. They get runny nose, cough. And patients with CF really don't get lung disease for the first year or so of life. And they don't get lung disease in the newborn period. Furthermore, PCD patients tend to have a better outcome than CF patients. And if we take a look, these are a number of studies, and I can just show you that in some of these, ciliary clearance was faster in CF, faster than normals. In these, they were the same. There were no, these ones, those with productive cough had normal tracheobronchial clearance. These had them being decreased, whole lung, so it's a whole mix. And looking even further, the problem with CF sputum isn't that it's viscous, isn't that it impairs clearance, but it's incredibly tenacious. It is sticky. So when you think about it, if I were to put chewing gum on this carpet and it was covered with saliva or it wasn't sticky, I could pick it up easily. On the other hand, if it wasn't and it got stuck in the rug, it would be very difficult. And if you thinned it and it blended in, it would be worse still. So to remove that gum, if you will, that sticky gum, you need to make it unstick. This is a study that we did a number of years ago, looking actually at the tenacity, which is a combination of how sticky it is and how stringy it is. And what we showed was that 32 dynes per centimeter is the normal airway, what you expect. And that's because there is some surfactant in the normal airway. 71 dynes per centimeter is water. This is not sticky and not less. Bronchitis is a little bit more sticky, CF dramatically so. And so it's that tenacity that makes the difference. Another myth is that there is more mucus in the CF airway. These are studies, again, from my lab where we looked at normal mucus in CF sputum. Now, most of the work up till that time had been done with sputum that patients cough out. We developed a technique for studying healthy mucus, which until then had been difficult to get to. If I were to ask any of you to give me a normal mucus specimen, unless you had lung disease, you wouldn't be able to. So what we did was we had patients who would come into the hospital and they would require surgery. They would have an endotracheal tube placed, and they would have normal lungs. It wasn't lung surgery. And at the end of the procedure, when the anesthesiologist removed the tube, they would go to throw it in the wastebasket, in the dustbin. One of my lab people would be there with a catcher's mitt, grab it, bring it back to the lab, and scrape off the mucus. And what we found was that intact mucin was decreased in sputum. And you can show here the main mucins, MUC5AC, MUC5B by both dot blot and by Western. Now, there is more mucin in the airway, but it's broken down by enzymes. And for that reason, breaking down mucins further using things like acetylcysteine are of no value. It does nothing in CF. And there are multiple studies that show that using acetylcysteine can actually worsen lung disease in CF. What about COPD? Mucomyst is acetylcysteine. This was a large study called the Bronchus study, where they looked at acetylcysteine in patients with COPD compared to placebo. And they looked at the change in FEV1, pulmonary function, over time. And I can tell you that over these 36 months, comparing the two, you don't need to have a degree in statistics to see that there's no difference. Well, what about pulmozyme, Dornase alpha? Pulmozyme breaks down that secondary network, the network of DNA, doesn't affect the other polymer network. And it was thought that if we can develop this for CF, there are only 60,000 people with CF in the world, but my gosh, there are 20 million with COPD. Maybe we can make this a blockbuster drug. So they did a small study with patients with really severe COPD, probably with bronchiectasis. It was not big, and they looked at changes in lung function over 2 months while they were taking pulmozyme. And there was no difference, the same. But they stopped the pulmozyme and they continued to follow the patients out. And surprisingly, they found that after 6 months, there were fewer deaths in those patients taking pulmozyme. So they said, aha, it prevents mortality. So they did a huge study, a study that was going to include over 5,000 patients, called the Chronic Obstructive Pulmonary Disease Mortality Endpoint Trial, Mortality wasn't their initial thought. But because of this small study, they wanted to make this the whole thing international. And then, after they had recruited almost 4,000 patients, they looked at safety. And what they found is there was increased mortality, increased death in those patients in this big study that received Dornase. In fact, the relative risk was almost significant, 70% greater risk of death over the period in those patients who were taking pulmozyme with COPD. Well, they said, well, that's different. That's COPD. Bronchiectasis, we know that that's more similar. CF patients get bronchiectasis. And so Bob Fick, who was with the company Genentech that made this, set up a study, again, of 350 adults with idiopathic bronchiectasis to see if they would improve with pulmozyme. And it was a randomized, double-blind, perfect study, 350 outpatients in Ireland, Britain, and North America. And at the end, they found not only was it ineffective, it was potentially harmful. And that in the pulmozyme group, there was a greater decline in pulmonary function and more hospitalizations and more exacerbations. Not to give up, they said, what about asthma? So in the Netherlands, they did a study in children with really severe asthma, comparing pulmozyme to placebo, and they found really statistically no difference in lung function over a period of 7 weeks, although placebo actually gained lung function, probably because of something called the Hawthorne effect, being on a study. And I'll tell you about that near the end. So the bottom line is, just because something works for one disease, it doesn't necessarily work for another. All of these were very good thoughts, but they were wrong. There's also the myth that CF mucus is dehydrated. Now, that's a term that's used. We're going to continue using it, but I don't want you to think that way. Dehydration means water loss and concentration of solutes, whereas uninfected CF mucus is isotonic, and the periciliary fluid is isotonic. The volume is low, and it's sticky, but it's not particularly dehydrated. And if you think about somebody in the desert who is really dehydrated, what do they want to drink? Not 7% saline. So hyperosmolar saline isn't really a hydrator. It induces fluid secretion, it induces cough. It's effective. It doesn't really hydrate. Now, I'm not going to change what people say with this. I haven't been able to change other people's ideas on other things. For example, all of you listen to patients' chests, right? Of course. And you listen to it with a device that has got the wrong name. So I will ask you, if you were going to look at a distant star, you're going to use a telescope. Exactly. And if you want to call home in Chile, you use a telephone. Exactly. And if you want to look at something really tiny, you're going to use a... And what is this to make my voice bigger? Sure, nobody looks at a chest with this instrument. It's not a stethoscope, it's a stethophone. But nobody's going to listen. I'm glad you did. Hypertonic saline improves pulmonary function in CF, but only in those patients that have low pulmonary function. This is a study a very nicely done study out of Johns Hopkins, where Beth Laube had patients inhale a tracer and measure their clearance. And then they had these same patients take saline and inhale the clearance. And they found for all children there was a non-significant difference. But then they broke it down and found that those patients that had low baseline mucociliary clearance, those in blue, improved. Those that started out with normal mucociliary clearance, clearing within 30 minutes, didn't have a change. What about steroids? Well, we know patients with cystic fibrosis have airway inflammation, and steroids fight inflammation. Of course. Well, the problem is when you add corticosteroids to their burden, it increases the coughs, increases time, and again, it doesn't take a statistician to see there's no difference in the study by Ian Balfour Lynn that adding steroids make a difference. And that's because the inflammation in CF is neutrophil dominant. The steroids extraordinarily effective against T2 inflammation, eosinophil dominant, nothing for neutrophils. Talking a bit about asthma. Baby wheeze. Wheezing with viral colds is not associated with bronchial hyperreactivity in children. Multiple studies. And double-blind randomized controlled trials in young children under the age of 3 with viral wheeze, so no response to bronchodilators or to steroids. And there may be, in the youngest child, a risk of alveolar maldevelopment. Now, if you have recurrent wheeze, if you have wheeze that's not triggered by viruses, if you have wheeze with a virus and you're allergic, yes, treat those small children like asthma. But this time of year, where children are coming in with their first wheezing with what we call bronchiolitis, we know we don't use salbutamol or steroids or hypertonic saline. So if you're giving an aerosol, how do you want to get it to them? And sometimes we'll hear doctors say, oh, he's crying, that's good. It'll get things deeper in their lungs. But if you think about it, the way to get medicine deep in the lungs is to breathe in slowly and deeply and hold your breath. And in this study, Murakami looked at infants who were taking a nebulizer, and a lot ended up in the mouth, but when they were quiet, you had really good outline of the lungs. If these children were upset and crying, you ended up with a lot in the mouth, the esophagus, and swallowed in the stomach. Very little goes to the lungs. What goes to the stomach does produce some effect, but also produces side effects. If you take a look at an infant that's crying, this is looking at deposition of chromalin, and again, we're not using it anymore, but the good thing about chromalin was it's excreted intact in the urine, so you can measure the amount that's absorbed. What comes out in the urine has to have been taken from the lungs. And when babies were quiet, you got a reasonable amount that went in, and when they were crying or distressed, there was none. And I said that when you breathe in, you have to breathe in slowly, deeply, and hold your breath. But a baby does exactly the opposite when they're crying. It's a long exhalation and a rapid inhalation. And so there's only one effective and efficient way to give medication to a crying baby. And that's you measure what goes into the nebulizer, you smile at the baby, you pour it into the sink, and you leave. Because the patient will get exactly the same, but you'll have saved time. What about giving it blow-by? The child's crying. What if you put it in front of their face? Maybe something's going to get in. They call that blow-by when the child's quiet and just, I don't want to be bit. Well, small children can be uncooperative. They may sit still, but there's almost no medication delivered to the lungs. And here's a very nice study out of Australia where they had not a baby, but they had a face. They had a mannequin that had a mouth and a nose and a trachea, and they would do a breathing. They would have a filter there, and they would go through it. And so unlike a child that's wah, 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 this was us. So they put it right on the face, and they measured what came in. And then they took it out, 1 centimeter, and then 2 centimeters. And they measured what came out. And in this model, just pulling it out 2 centimeters, 1 inch, with the mouth open, reduced the amount that got on that filter by 85%. So, when you're using a nebulizer, should you use a mask or a mouthpiece? And does it make a difference? And in fact, it does. Using real studies in real patients, these are looking at children 3 to 6 years of age. Now, infants, they have to use a mask. They won't be able to suck on a mouthpiece. And you get very little in the lungs. But if you are able to take these children and switch from a mask to a mouthpiece, you can double the amount that gets into the lungs. And so if they're able to use a straw, if they're able to make a seal, if they're able to use a mouthpiece, it's more effective. Less gets into the face, less gets into the oral pharynx, and more is breathed directly into the lungs. I want to talk a bit about cough, and I'll be talking about this again tonight, so I'm going to go through this a little bit quickly. Cough medications. Cough is unpleasant. The drugs were approved. However, in 2009, cough medications were banned in the US for small children because of side effects. There is no evidence that they worked, and this includes decongestants, antitussives, expectorants, but they have been associated with toxicity, particularly in children. And I'll refer you to this article in Pediatrics. But the reason why people keep using it is because there is a huge placebo effect. Eccles and all have reported that the placebo effect for giving somebody a cough medication when they're coughing, even if it's placebo, is as high as 85%. And a very good study, this was in adults, but in children, there was a study done where the parents brought the child in and were given either placebo or they were given cough medications, antihistamine decongestant, or they were given nothing, 3 choices. And when they came back, those who received nothing, the parents would say, "Oh, no better, doctor. I told you he needs something. He needs augmentin. He needs azithromycin, antibiotics." But those who received placebo and those who received the medication had exactly the same response. So what about salbutamol? No role in treating chronic cough. And there have been multiple studies. This was archives, but Ann Chang also did an archives paper on this. Children with chronic cough rarely have asthma as their primary diagnosis. I'm going to talk about this more later. This study, also from Ann Chang's group in Brisbane by Julie Marchant, showed that asthma, gastroreflux, and postnasal drip combined accounted for less than 10% of cough in this large study of small children. This persistent bacterial bronchitis, or now they call protracted bacterial bronchitis, was more common. And in fact, if you look, things like aspiration and was even more common than these others. This time of year, as children come back to school, what we see are the children that get short of breath with exercise. And typically they've been given salbutamol by their doctor, and they're still short of breath with exercise. So Mike Weinberger and his group looked at 115 children and did formal testing. They brought them into the exercise lab. They measured their oxygen, their metabolic, they measured their pulmonary function, they measured outcome, and they had them exercise until they were dyspneic. And what they found was that 2/3 of these had what's called physiologic. They met their limitation. And this is common. Kids who have been in quarantine, have been isolated because of pandemic, are now out and exercising again. Children who have had a summer where the only thing that they were exercising were their thumbs, now are back, and suddenly they're in a bigger grade at school, and they're short of breath. I remember I had a young woman a number of years ago who was a high school student who was a very good athlete. And she came to me in September and she said, "Dr. Rubin, I get short of breath now when I run 10 miles. And I said, "Oh, I understand." People reach their limitation. How many of these? Well, what else did they see? Well, they saw a significant proportion, this was about 13%, with restrictive lung disease. In this case, many of these patients were obese. They saw about 11% with vocal cord dysfunction, but asthma, exercise-induced bronchospasm, only 9%. So yes, children who have asthma and are known to have asthma get short of breath with exercise. People who don't have asthma get short of breath too, but it doesn't mean they'll get better with salbutamol. Bronchodilators for tracheomalacia. Now, kids with tracheomalacia are wheezy, but their airways are supported only by the muscle. And so a study done by Howard Panic and the like looked at these infants with tracheomalacia, the ones that had survived the nursery, and measured their lung function. And they did this using infant lung functions, and then they gave them bronchodilators. And they found that they became quieter because the muscles would relax and you would collapse down. And so we're no longer using bronchodilators at all for tracheomalacia. So in summary, here, this was a study. If you listen, can you tell by listening if the child's doing better? We use bronchodilators for wheezy infants because we know they get better. We listen to their breath sounds, except the study by Wilson showed it was useless. when they actually measured lung function, again, you were hearing what you wanted to hear. And this was the outcome of another study saying the stethoscope is unreliable for assessing respiratory sounds in infants, which has important implications for a diagnostic tool. So, should you give salbutamol for chronic cough, dyspnea, chest pain, wheezy babies, pneumonia, bronchitis, CF, ARDS, croup? Well, salbutamol cures everything except for stupidity. So I'm going to end by talking a little bit about evidence-based medicine, and it serves two purposes: to identify practices that are associated with best care, and often we don't have enough data. So it's to identify areas where there are too few data to make good recommendations, and you need to do additional work. So for a good study, you have to have a good question. It has to be valuable with a single clear outcome variable, powered, conducted, and then reported. So you can have a good hypothesis, but a bad study design, like that Comet study. And here, testing whether laughter is the best medicine. That isn't the best study design. You know that there's a placebo effect. And in here, the pharmaceutical company is saying 9 out of 10 doctors recommend the placebo instead of our drug. And I did mention the Hawthorne effect. And this is a very interesting study. Back in the late 1920s and the 1930s, there was an electric plant, Western Electric Factory in Hawthorne. And if you take a look, they're all women, all nicely dressed, putting together electrical components. There's a little bit of light from there and from there. And those were the days where you had efficiency experts. And the efficiency experts would come in, and they'd have their little piece, and they'd stand beside you and see how efficiently you're eating your fruit, how quickly you're doing it, how much you clean. And what they found is when the efficiency experts came in and they measured how quickly the women were working, how efficiently, they then turned up the lights, and things got better. And they turned up the lights even more until it was really bright, and things got better. And so they ended up saying, aha, better lighting makes for better outcomes. And then they left and turned down the lights, and things stayed good. Because it wasn't the lights that was being observed. So being in a study means the patient knows they're being observed, and they're more likely to do the things they were doing anyway. And we refer to that as the Hawthorne effect. Productivity, or the patient getting better only because they're in a study. Are the points valid? Was there a long enough follow-up? Was it a good sample? Did you use unbiased outcome criteria? And did the investigator have a bias? Who paid for the study? You know, there have been studies over the years. This was one of my favorites. 20,000 doctors, big study, say that Lucky Strikes are better for your throat. They give you throat protection against the irritation of cough. Yeah, probably biased. And don't confuse cause and effect. This is from Virginia, where I'm from, where this woman was noting that she was worried, she was pregnant, and thought the sounds of the construction were going to have a bad effect on her child. And can it be generalized? If you do a small, very select study group, can you then generalize it to a larger population? And here we have the people saying, Mr. Darwin, have you reached conclusions so far? So, summary for evidence-based medicine, it's not cookbook. It doesn't eliminate the things to think about. Grading is subjective, publication bias, and even bright clinicians aren't immune to the placebo effect. The eye doesn't see what the mind doesn't know. And so with that, I want to leave you with the thought by this very eminent scientist that only two things are infinite: the universe and human stupidity, and I'm not sure about the universe. Thank you very much. Bon appetit, and I will take any questions, comments, arguments, fights. ¿Preguntas? Bueno, come mucho. And turn that off. There you go. Thank you, sir.
I have a question.
Sí.
Last week ago, you have a paper on the
And my favorite, myths and problems. Yes, it just came out. Perfect. Over the years, I've enjoyed myth busting. It's been an easy way to have fun and to write papers. So yes, I went through all of the things we've used for bronchiolitis over the years. Next year, I'll have that as a presentation.
So my comment is we have a lot of bronchiolitis in Guatemala, a lot of respiratory probably. And but at the end, you tell in the paper that nothing is working in bronchiolitis. And I am sure that's our experience. But how you manage the parents, the problem?
Well, there are things that work in bronchiolitis. Remember, the babies are nose breathers. And so keeping the nose clean, suctioning the nose, making sure they're getting hydrated and nutrition, making sure they're comfortable. If they're hypoxemic, give them oxygen. And time and the Lord. Those are the main things. All right.
I have a question. Is there any myth about viral croup in the use of steroids and epinephrine? It's still dogma.
I still think it works. I think the data tends to show that using epinephrine, and there's a shortage in the States of racemic adrenaline now. The other epinephrine is perfectly fine, levoepinephrine, still relieves things potentially, and steroids will also prevent them from getting worse. But there was an old myth about this rebound, that you shouldn't give inhaled epinephrine because they'll get worse. And in fact, when it wears off, they do get bad, but they don't get worse than before. It does buy time.
Even if it's viral, it works. Steroids?
Yeah, because of what the virus induces is vascular congestion, inflammation, and this helps to relieve that. It helps shrink the vessels, and the steroids reduce the secondary inflammation. Or at least that's what we think. That may be completely wrong, but that's the current thought, and it seems to work. Yeah, and we're very quick to give a dose of steroids. Not so quick with adrenaline. It's when they're really having difficulty breathing. And we figure one bit of steroids may prevent them from coming into hospital. Yes.
I have a question with the elder children. What happens when they have a lot of cough? What do you think about medicine that has combination of different types of eucalyptus or different things to make the cough go away? The elder children, we can use them, but I don't know if you prefer syrup that has one medication or those that have different combinations of medications for the cough.
Are you coming to the talk this evening? If not, contact me, because it's all about cough, and I talk about the data relating to that, including some work that we've done looking at guaifenesin and other studies. And in fact, as I mentioned before, the secret, if you will, the punchline for the joke is the placebo effect is very strong for cough. One of the best reasons for giving one of these medications, these placebos, is so that they'll stop calling you all night saying, it's 2 o'clock and he's still coughing. It's 3 o'clock and it's still coughing. I know. It's 4 o'clock. Put the lime in the coconut. Thank you.